and they asked the question, in adults with suspected community-acquired pneumonia, should routine diagnostics include nucleic acid-based testing of respiratory samples for viral pathogens other than influenza? And their recommendation that this was appropriate in the inpatient setting, not for outpatients, and certainly for hospitalized patients, they recommended that it was most useful in patients who had either a severe pneumonia, who were very unwell, or were immunocompromised. The European Respiratory Society has gone a little bit further than that, and their more recent guideline, which was issued in 2023, suggested that if the technology is available, they suggest sending a lower respiratory tract sample, so either a sputum sample or an endotracheal aspirate, or even a bronchoalveolar lavage if that was appropriate for the patient, for multiplex PCR testing. So they've quite specifically suggested the multiplex testing there for viruses and or bacterial detection, depending on what's available in your healthcare facility. Wherever non-standard community-acquired antibiotics are prescribed or considered. So if the patient does not seem to be responding to standard community therapy, they are recommending a multiplex PCR as a part of routine care. They do note that this is a conditional recommendation because at the time that they did the review, there was a very low quality of evidence. But they thought most of the benefit would be in the ability to adjust antibiotics so that you can give a more targeted therapy for the patient, and particularly to minimize inappropriate and also potentially toxic antibiotics for the individual. It's hard to measure, but they also felt that it would be potentially reducing antibiotic-resistant infections within that patient population. In addition to their recommendations about testing, they actually had identified several areas of need for research priorities, and most of those were around the safety and cost effectiveness of discontinuing specific therapies that were no longer warranted once you knew which virus the patient was infected with. And they're actually quite specific about what studies ought to be done in the future, and there is still a lot of work in this field to be done. So what do we know in terms of an evidence base for multiplex PCR? So there have been quite a lot of studies that have been done, not an infinite number, but quite a lot, and one quite substantial systematic review and meta-analysis, which I'll present to you now. So this was published in 2023 in the Journal of Infection, and they reviewed the literature and were able to find 27 studies which were of suitable quality to include in a meta-analysis. And there was more than 17,000 patients in this group pooled all together. However, only 8 of the studies were randomized controlled trials where multiplex PCR was tested against the usually what was the previous viral testing or anti-infective testing panel that was available in that hospital. 2 were quasi-randomized controlled trials, and the vast majority, or 17, were observational cohort studies. So this was usually where a new technology was introduced and it was compared against historical controls to see what difference was. And at that time, most of the studies that were performed with this used the BioFire technology. So they looked at many different aspects of care and things that had changed as a result of using PCR technology, but this was probably one of the strongest findings that they found, which was that consistently in each of the studies that they looked at, the time to diagnosis was considerably quicker between when one used a multiplex PCR. And as you can see from the forest plot, on average, that time to increased time to diagnosis was 24 hours earlier. So that can be quite significant in someone's clinical care, particularly if they're deteriorating quite quickly. They did look at other questions aligned to that, including, so knowing an earlier result, does that affect other things in terms of care? And it did indeed decrease the hospital length of stay by 0.8 of a day. Now that to an individual, less than a day in hospital might not seem like a very substantial number, but to the hospital management, reducing length of stay by a day is really quite substantial, and there's huge costs in reducing hospital stay. Amongst influenza positive patients, they found that, and this was the group that was most consistently analysed, they found that antivirals were more likely to be given if they had a clear multiplex PCR diagnosis, and also that appropriate infection control was much more commonly done when patients were known which virus that they had because of looking at the rapid panel altogether. So one clinical question we are often asked is which sample is the best sample to use for a multiplex PCR to try and get the answer that you want of what the patient might be infected with. And there's often risks and benefits of doing samples in different places. Certainly, we can do multiplex PCR on multiple biological samples. As a respiratory physician, we almost usually do them on nasopharyngeal aspirates, occasionally on sputum samples, endotracheal samples, or if we have the capacity, we'll do a bronchoalveolar lavage. So nasopharyngeal samples are very minimally invasive. They're quite safe to obtain. There is quite a bit of operator variation in how they're done, and you know, occasionally we won't get a substantial enough biological sample for the sample to process very well. I think thanks to COVID and all of us having lots of swabs at various times, we've all become better operators at this. So that's, but it's certainly an easy thing to do. And in my hospital, most patients will have that done on presentation to the emergency department if they're likely to be admitted with a respiratory condition. Lower airway samples, we've always thought, are more likely to contain the causative pathogen, particularly in a pneumonia, because that's closer to where the disease is. So a sputum sample, or if possible, a bronchoalveolar lavage sample. Of course, doing a bronchoalveolar lavage is not without risks, particularly in the patient that has pneumonia and particularly if they are hypoxic, but it can be a very valuable sample. So the French study that I'm about to show you had 285 paired results. So all of these patients were admitted to hospital and had both a bronchoalveolar lavage and a nasopharyngeal swab during the same hospital admission. And this study has compared whether the results are comparable. And pleasingly, there was a very high concordance of positive results. So 85% of these patients had the same organism in both their nose and in their bronchoalveolar lavage sample. However, there was a substantial group of 13.8% of the patients who had a negative nasopharyngeal swab, but when they went on to have a bronchoalveolar lavage, had a pathogenic organism identified. So that was very clinically useful for those patients. The concordance varied by viruses. So some viruses were more likely to be captured in the bronchoalveolar lavage. In particular, those were RSV and influenza. They had much more substantial yield there. And some viruses were more likely to be seen only in the nasopharyngeal swab. And that included, not surprisingly, rhinovirus. So I will show you quite an interesting infographic that demonstrates this in a little bit more detail. So it's from the same paper. On the left, so we've got two diagrams presenting the data in different ways. In the left panel, the inner circle represents the organisms shown by nasopharyngeal swab, and the outer circle shows the organisms demonstrated by bronchoalveolar lavage. And so you can see there's a very high correlation there with para-influenza, the nasopharyngeal swab being predictive, but not so much correlation with rhinovirus being present in the BAL sample. When we look at it the other way around, which samples were present in the BAL and not in the nasopharyngeal swab, we can see that the BAL overall was much more sensitive, not surprisingly, particularly for things such as influenza and human metapneumovirus and RSV, but for rhinovirus was more in the nasopharyngeal area. So doing all of these testing on many different, multiplex testing on many patients has allowed us to not only see the patterns of what's been presenting in our hospital, but it's also helped us to do a little bit of a clinical deeper dive in some of the less common viruses. So this is some data that we presented at ERS last year from our hospital. We had seen a particular spike in human metapneumovirus, and it's a virus that most people hadn't paid very much attention to beforehand, but because we'd done the multiplex PCR testing, we knew exactly how many patients had had it, and we could identify those, and we could look at their clinical characteristics. So this is just showing you the cases on a time scale. So we had this quite striking peak in September and November of 2022. It was just sort of following our COVID pandemic wave. And we were able to, when we looked at these patients who had human metapneumovirus and compared them with patients admitted to hospital with RSV and influenza at the same time, we were actually able to see that they were in similar ages, slightly more likely to have comorbid disease, and certainly became very, very unwell. So they were just as likely to need to go to intensive care and have, they actually had a higher rate of death, unfortunately. So human metapneumovirus is a small virus that we hadn't really paid very much attention to, actually was causing very significant illness in our patients in the hospital. So doing this sort of broader multiplex PCR has given us the capacity to look into some of these lesser known viruses in our own cohort settings. So that's just a brief view of my view of what multiplex PCR has been able to add to our hospital. I think that it's a useful tool to rapidly determine the presence of different respiratory viral infections in our patient populations. It allows us to tailor individual patient care with better targeted therapies, which we now have, particularly for COVID, but for many of our viral illnesses, and I think will increase in the future. It allows us to reduce the adverse effects from unnecessary therapies. It also provides a foundation for targeted infection control within institutions such as our hospital, and that has very significant healthcare and cost implications. And it also provides epidemiological data for planning a healthcare response and also some community messaging both to our patients and healthcare providers in our near region. Thank you very much.
Thank you. Thank you for Dr. Megan. So I appreciate your excellent and comprehensive lecture. Thank you so much. So now I hand it over to Dr. Stephen Batman to introduce our next speaker. So Dr. Stephen, please start.
Thank you, Dr. Fujita, and thank you, Megan, for that great snapshot, particularly salient given we're about to head into our flu season, and obviously part of the brief around why we timed this webinar for this time of the year, because this year we're not really quite sure exactly what it's going to look like, but everybody's kind of holding their breath and waiting and watching it at some levels. I wanted to talk about three quick things before I move on to our next important presenter. The first is just to thank the Asia Pacific Society for Respirology in relation to their ongoing collaboration with us in offering these particular webinars. This is the first webinar for this year, and then there will be another one later in the year. And secondly, on behalf of Cepheid in Australia and New Zealand, I just wanted to thank our presenters and panelists for giving up their time today. People have busy lives. And also to particularly thank Gordon Chase, who is from the US and is joining our panelists a little bit later on. I think it's now 1:30, 1:45 in the morning, roughly, Jordan, on the east coast of the US. So many, many thanks for making the time to try and keep your eyes open at this hour of the day. The third brief thing I wanted to mention for both our Australian speakers and panelists is an important custom, which is about acknowledging the different traditional lands of the traditional owners of this country. That varies from state to state. So on behalf of myself, of Megan and Belinda and Dominic Dwyer, I'd like to pay our respects to those traditional owners and to those particular traditional leaders who are either past, present and emerging. And so with that in mind, and that is a very important segue into our next presentation, I'd like to introduce you to Dr. Belinda Hengel. Belinda is a postdoctoral research fellow at the Kirby Institute at the University of New South Wales in Sydney, Australia. And today, Belinda is going to present on the impact of molecular point-of-care testing with Xpert tests for respiratory infections in remote areas. Belinda has a PhD in epidemiology from the Kirby Institute and also a postgraduate certificate in public health with a specialty in and a particularly strong focus on sexual health. Belinda has a number of publications to her name, including a decentralised point-of-care testing model to address inequities in the COVID-19 response, plus other key and important publications focused on the rates of syphilis in women of reproductive age and congenital syphilis in Australia. Her focus is on reducing the impact of infectious diseases, including sexually transmissible infections and respiratory infections in populations at risk. Belinda has significant experience, I'm adding that word significant in Belinda, because I think it's important, to the implementation and evaluation of public health interventions, including molecular point-of-care testing in remote communities and optimising health service delivery. So welcome.
Steve, I'll just share my slides, one moment. And just moving some things around so I can see properly. Now, I'm assuming that's shared okay with everyone?
Yes, thanks.
So thanks so much. And thanks also for the invitation to speak today about the First Nations molecular point-of-care testing program. I'm really delighted to share some of the work with everyone online. As Steve mentioned, it is a custom for us to acknowledge the traditional owners of the land. So I'm dialing in from the Bunurong lands down in Victoria also. Victoria seems to be well represented here today on this presentation. Got a couple of disclosure slides here. The First Nations molecular point-of-care testing program has received some cartridges initially for the rollout of this program that I'll be talking to you today from Cepheid, and no other conflicts of interest to declare. So today I'll be speaking about giving a little bit of background, I guess, into the remote settings in Australia. We'll talk about the Australian COVID-19 response, and then we'll move into routine primary healthcare and the next steps. So let's start with a little bit of background and a map of Australia. I'm dialing in today from, you can see my waving little hand there, from Melbourne, just outside of Melbourne actually, in Victoria. And we'll be focused, instead of talking about Melbourne settings that Megan talked about as well, we'll be looking at remote areas of Australia. I've worked and lived for many, many years previously across lots of these regions in Australia. In Australia, the majority of First Nations people live in regional and urban areas. However, around 20% live in remote areas, which are shown at the blue dots on the map on the left-hand side of the screen. Many of these communities are quite small, as you can see with the photo of the community up on the right. They can have one health service caring for the whole community and nearby areas. Now, these primary care clinics are staffed by just a couple of nurses and some Aboriginal health workers, maybe a doctor, or that doctor would be fly in, fly out, as well as specialist services are fly in and fly out. Now, these clinics are super busy. They offer the full range of care, from acute care to chronic disease management, child health care, sexual health, mental health care, you name it, they offer it out of these services. These areas in Australia are beautiful, with deep connection to the country and the land for many of these communities, but they are super remote. They are hard to get to, often getting cut off for months months at a time, with specialists flying in, flying out, and medical staff flying in, flying out, and often not being able to get there. Here's a picture of a remote community that I've worked in over a few years. With the airstrip flying off that cliff, it was quite terrifying. And sometimes that airstrip would get cut off if it was in the rainy season, and you wouldn't actually be able to access. The community would be completely cut off from the outside. Within these areas, there is limited access to healthcare. In particular, tertiary care is often located hundreds of kilometres away. Residents live in large household groups, and rates of chronic disease are high. Among all these complex factors that contribute to health inequity in these areas, one factor is simply the sheer distance of these communities from centralised laboratories. While Australia has a reputation for world-class centralised laboratory network, unfortunately, access to this service is not equal for everyone. The large distances and delays in diagnosis and treatment have a significant impact on the health and well-being of people living in these areas, which I've demonstrated through the couple of pictures here. On the right, you'll see the map of Australia, and the yellow box being the area that I've zoomed in on for the left. It shows the distance between Darwin, which is the capital of the Northern Territory, and the small community, which is the yellow dot called Borroloola. It is located just under 1,000 kilometres away from Darwin. Now that takes over 11 hours to drive to Darwin, which would be the nearest laboratory. And in many seasons, in the wet seasons, that would be cut off as well. So let's think back to COVID in 2020. In the early stages of the pandemic, the Australian government, and led by an Aboriginal and Torres Strait Islander governance group, recognised the particular needs for remote areas, including this limited access to care that I've talked about in terms of fly-on staff, small community health centres that were only staffed by a couple of health staff. They decided that point-of-care testing, having access to that within the health services, would allow for continuity of care where physical access was limited, improving health equity. It made the result available on the day to help with treatment decisions, as Megan went through, isolation decisions, and contact tracing. During the COVID pandemic, before point-of-care was available in the remote sites, patients had to be moved, in some cases, by flight, by plane, over a distance of nearly 2,000 kilometres to a nearby area to wait for their results, with respiratory cautions because they didn't know if it was COVID or not, and wait for results away from their community and away from their family. Having access to point-of-care testing meant that this isolation and potential transfer of a patient out of community didn't have to happen. So knowing this, funded by the Australian government and in partnership with Flinders University International Centre for Point-of-Care Testing, we worked closely with a network of collaborators, so laboratories, Aboriginal health services, government health departments, and we leveraged an existing network of Xpert devices, which were testing for STIs at that time, chlamydia, gonorrhea, and trichomonas, to enable testing for COVID-19 within the health clinics, meaning that results were available within 45 minutes, not 6 days, which was happening at that time. We trained up Aboriginal health practitioners, registered nurses, and doctors. The map on the right that you can see there shows all the participating sites, with the pale yellow and beige sections being the most remote areas of Australia. Some of these areas, as I mentioned, were up to 10 hours drive from the nearest laboratory that was able to test for COVID. We deployed 4 module devices, as you can see in the photo here on the top. And in some of the bigger clinics, we deployed 2 of these so they could do up to 8 tests at a time. Now, a brief note on our framework that we used to implement this program. We maintained the patient at the centre of the framework. As long as quality standards were maintained, staff were trained and competent to use the point-of-care device, and we met the Australian accreditation standards for point-of-care testing, the clinics could use a point-of-care test as they needed. They could do outreach to patient homes, they could offer testing outside the clinic, they could test clinic staff to make sure that they were infection-free and the clinic could stay open. We worked alongside regional centralised laboratories to complement their network, acknowledging that these devices were not high throughput devices and that clinics would often still send samples that were low risk to the nearest laboratories during busy times. Our system throughout COVID included a positive result hotline, which the point of care operators within the clinics could call to verify the result, which would then initiate the public health response. The devices located in these clinics were connected to a laptop, and we had software installed that enabled real-time transfer of results to the clinic's electronic medical records, or to notify public health surveillance departments to initiate that public health response. Now, I've just included a couple of media snippets here from the response during COVID. This one shows the importance of a positive result within a remote community. This was in the Northern Territory in Australia. The device within a health centre detected the first case in this particular community called Robertson River. It then initiated the public health response and had public health staff out to this community within 24 hours. They initiated a quick lockdown and the emergency response team was deployed, as I said. That community was declared COVID-free within 3 weeks of the first case being detected. What many people don't think about, however, is the importance of a negative result. Megan touched on it with saying earlier about the importance of finding out what the result was to look at infection control measures that need to be put in place for that infection. For COVID, in this particular setting, we had a community called Balgo, which was where the first test was done back in May 2020. An elder presented to the clinic with respiratory symptoms. They had the gene expert, they had just had staff trained up to use it. And prior to having that, she would have been evacuated by air to a nearby regional area, placing a huge amount of stress on her, her family, and at a cost to the health service of nearly $20,000. Having the gene expert meant that they could test her on the spot, find out she was COVID-free and keep her in community, thereby saving her stress as well as the healthcare costs at that time. So looking back over that COVID period, we provided rapid, accurate results for over 70,000 people. The devices and the staff on the ground in the clinics detected the first cases in nearly all of the remote communities that were participating in the program, triggering public health responses within 24 hours. Having that result supported mass swabbing campaigns, vaccination, contact tracing, and community lockdown. It enabled staff to keep working in the community, minimise that need for evacuation, and that timely diagnosis supported rapid use of appropriate antivirals. After the COVID pandemic started to become a bit more under control, the Commonwealth initiated an external review of our program by a group called NOUS. You can look up the report, I've got the link there. Now, they looked at how the impact of the program within that first 40 days after a positive result was to hit a remote community that otherwise did not have COVID. Here they found that having access to the Gene Xpert device and initiating a public health response because of that, it averted between 23,000 and 122,000 infections in remote Aboriginal and Torres Strait Islander communities in Australia, and thereby also avoided an estimated costs to the health service of between $337 million to $1.8 billion over that period of the initial COVID response in those areas. They found that the key factors that underpinned this success were a well-informed and culturally competent governance, the Gene Xpert system, and the technical support provided by the Kirby Institute and Flinders University International Centre for Point of Care Testing, and the model that was provided from the health services on the ground. Now let's switch gears a bit and transition from the emergency response to present day. Stakeholders advocated for the program to transition from using SARS-CoV-2 only tests to offering SARS-CoV-2, RSV, and influenza A and B in the one test. The graph on the right shows when the transition to what we call fourplex testing that happened around mid-2022. Each jurisdiction there in Australia is represented in the various coloured lines, with the Northern Territory, where most participating services, present in the orange lines. All the patient tests done is in the grey line. The timeline starts at the start of COVID with 2020, and you can see up until the end of 2024. Test numbers have remained consistent over time, with some services using the device more than others, as you would expect. We are just under 90,000 tests to date. That might seem a small number, but if you recall the photos that I showed earlier on, these are really small communities that we're talking about. Aboriginal and Torres Strait Islander people are considered at increased risk for severe outcomes for respiratory illness due to isolation and high rates of chronic disease. These devices are highly valued by many participating services. Particularly important, as Megan said, to diagnose when there are multiple viruses circulating in the community to help direct treatment or prompt medical evacuation out of the remote area. In 2024, the overall test positivity rate across the services and across infections was over 30%. Now I've got a little bit of data here to show you. Here we look at patient test positivity for both influenza A and B by age group in 2024. You can see the diagnosis of flu in these areas is fairly evenly spread across age groups, with a slight dip in the middle there of 30 to 39-year-olds. For influenza, early diagnosis means that they can give Tamiflu to patients who would be considered at high risk of complications. If they would have to wait for 6 days for a result to come back, it would potentially be too late for Tamiflu. Now moving on to COVID-19. Most diagnosis of COVID was found in the older age groups, with not as much at all in this 0 to 9 to 10 to 19. The older age group of the 70 to 79 is over 20% testing positive for COVID who were screened in those areas with respiratory illness. Now moving on to RSV in 2024. Most of those diagnosed were age under 9, which is the area where we are most concerned due to the impact of younger people for bronchiolitis and rapid deterioration and being located in a remote area. RSV will be an interesting one to watch with the rollout of vaccination programs. From what we've heard across these areas, clinicians have said that access to the rapid results has provided guidance on clinical management where previously they could only manage symptoms. For kids diagnosed with RSV who have comorbidities, it might mean that they medically evacuate that child to a tertiary centre, a regional hospital more quickly, rather than waiting for that child to decline. We've been told that they would also then be able to provide education to the parents and carers and watch that child more closely. Now, how valued is this test? Here's an example that I heard of in the last week or two from a remote community up in the northern part of Australia. That one small community had 2 influenza deaths recently. There was still influenza circulating in the community, and they were concerned about the increased risk of spread amongst the community while the community were gathering to mourn. Clinic staff had told our team that the doctors were relying on the Xpert system to guide diagnosis and give Tamiflu where it was indicated. Otherwise, they were going in blind and couldn't diagnose if they were waiting on laboratory results. So where are we at to now? This is a bit of a watch this space, and perhaps I'll present on this again in the future. We are conducting an evaluation to assess the clinical effectiveness, the acceptability, the barriers of facilitators, and the cost effectiveness of molecular point-of-care testing for respiratory infections at the moment. So hopefully I'll feedback more about the impact of timely management in these areas from prompt results in the future. A quick shout out to the amazing team that I work with who are pictured there in the middle, acknowledging our huge list of partners in delivering this program. It wouldn't be as successful as it was without them. And a little note on the artwork by our colleague Melanie Fernando, who has drew this piece for the program, and there's a short description there as well to go into what the artwork means for the program. Thanks, Steve.
Thanks, Belinda. Yeah, that's a wonderful summary. And I was, again, taken aback by the number of cases averted and by the sheer amount of money that was saved during the program's peak activity, to be able to save between 337 and $1.8 billion, is a staggering amount of money. And I think it's a testimony to not only your program, but also all of the partners and the willingness of remote communities to come together at such a critical time. So thank you for that. And it's really lovely to have a perspective here which is, I suppose, a little bit outside of the box. Typically, we tend to focus very much on hospital-based or urban-based respiratory infection foci. And part of the idea was, in having you to come today, is to add another dimension to just how important it is to be able to meet the needs of other populations at risk. So I think that was a wonderful summary of not only what has been done, but what is continuing to be done both now and into the future. So with that in mind, I basically wanted to take the opportunity to welcome our first panelists. I know our panelists have been waiting patiently in the wings for us to get through the first part of our webinar today, but I wanted to introduce you to Dr. Dominic Dwyer. Dominic is a medical virologist and an infectious diseases physician with New South Wales Pathology here in Australia. So a very warm welcome, Dominic, and thanks for your patience.
Thank you.
And I think, Dr. Fujita, I think you were going to introduce.
I welcome. Yeah, I welcome our next panelist, Dr. Jordan Chase, Senior Director, Global Health Economics and Outcomes Research, Cepheid. Welcome, Dr. Jordan.
Thank you so much.
So without further ado, I think what we'll do is we're just going to start with some questions for our panelists. I noticed there are 3 questions in the Q&A section, and we'll do our best to come back to those. I am mindful of the time. In Australia here, it's around about 4:30 in the afternoon, so we don't want to move too much into the evening space because I imagine other people have commitments. But with that in mind, Megan, I just had a quick question for you, which is in relation to how important you think early detection and differentiation of SARS, CoV2, flu, and RSV is, and how does it help manage patient populations? I know you touched on this a little bit earlier in your slides, but I wonder where this fits, particularly in relation to the elderly and also pediatric population. Do you have some thoughts and feedback around that particular focus?
Yes, thanks, Steve. So as I mentioned, there are specific therapies available for COVID and flu. So clearly, early detection and treatment is important for that. And we certainly see it in our hospitalised population. And Belinda's demonstrated how important that is in a remote community as well of vulnerable patients. But to focus on RSV, so this does affect the extremes of age more often. And there also are vaccinations available to protect these populations, which are just starting to roll out in our country, in Australia, and they're probably available in other countries in the world. It's important to know so that you treat people with the right thing when they do come to hospital, but many of these people come from the community and go back to the community, and particularly we have a large group of elderly patients that go back to supported care in some form, so they live with other elderly people in a nursing home or other care facility, and so knowing what virus they have is very important because that determines what precautions the care staff back where they have their permanent accommodation would need to do. So they might choose to do infection control precautions if that person returns to hospital. They may choose to test the people who also live in that facility to make sure they don't get further spread within that facility. So early timely diagnosis of RSV is particularly important for our aged care sector. And to some extent, the same things apply for paediatric populations where children are particularly vulnerable to RSV and particularly good at spreading it onto other children and other people in their family. So I think the early detection is very useful.
All right, thank you. Thank you, Megan.
So next slide, please. So Dr. Belinda spoke a very interesting trial for remote setting. So why should there be an urgency to test and treat patients as a priority in remote settings? So
thanks for that. I touched on this a little bit in my presentation, but to expand, I guess, these communities, although small, have people living in large household groups, often cross-generational, with elders living in that small house as well. There is high rates of individuals with comorbidities and multi-comorbidities, and even at a younger age, so at a high risk for really severe outcomes. Aboriginal and Torres Strait Islander people are overrepresented in hospitalisations for a lot of these respiratory infections. So in remote areas, it can take up to 6 days, we've been told from our participating sites, to get a result back from a nearby laboratory, which making a decision on what antiviral to give that individual who's presenting to you within 6 days, if you're waiting on that result, it can really delay treatment. We have been told that in cases they might test the first or second person who's presenting at the health service and then assume that lab result for influenza or COVID is what is then circulating in the community if they don't have access to point of care testing within the clinic. So it is really super beneficial for patients to be treated and have access to rapid results for lots of reasons. Thanks.
Yes, thanks. So, Dominic, once again, welcome. And I just have been wondering, how important is the accuracy of rapid respiratory PCR tests, and how does it help better prepare in a changing respiratory landscape? And I suppose this question is framed around the fact that we see so many different emerging variants. I know as a part of my role, it's something that I'm constantly monitoring in terms of the ability of PCR tests to continue to be able to detect those variants. And I just wonder, from your perspective as a virologist, what your thoughts are in relation to that landscape and some of the challenges in your work in, I suppose, trying to keep up with exactly what's emerging and being able to monitor that and keep pace with those changes. So I wonder if you'd care to comment about that.
Yeah, thanks very much, Steve, and thanks to the APSR for asking me to talk. Look, accuracy of testing is always important. Doesn't matter whether it's a rapid test that we're talking about here today or any other test that's done in a laboratory. So accuracy is always important, and that really means understanding the sensitivity of a test, in other words, the ability to actually detect the pathogen, and specificity of the tests, in other words, is a result that's generated, a positive result, is that actually correct? So accuracy is always important. I think with respiratory virus testing, and I think both Megan and Belinda have sort of referred to it, but there are a number of things that affect the accuracy of testing, respiratory testing in particular. One is around the collection of the sample, the ability to perform a swab, and the site from where the swab is collected. And we've heard sort of talk about that already, but it is worth pointing out that there are still some unknowns. For example, we know that SARS-CoV-2 During that time, everybody got used to swabbing themselves and doing a rapid antigen test and so on. But the testing, when it's performed on swabs collected at the end of the nose, it works very well for SARS-CoV-2, but works less well for influenza and RSV. So we still actually have some unknown or some questions around the sensitivity of testing, depending on where in the nasal passage the sample is collected, excluding bowels and so on that Megan referred to. The other thing that's important in the accuracy is the timing of the test in terms of when that test is collected and the onset of clinical symptoms. So clearly, the longer the symptoms have been present in general, the less likely the test is going to be positive. So that's also important. The other thing that affects the sensitivity and so on of testing is the disease prevalence in the community. So if the disease is common, then testing is generally more accurate than when the pathogen is uncommon. Now, for respiratory viruses, in a country or in a city like Sydney or Melbourne or Hobart, for example, then we know that most respiratory viruses, flu and RSV and the others, have a seasonal nature. So if they're testing in the middle of winter in people with respiratory illness, the testing is really good. But in tropical areas, for example, in Singapore and Indonesia, flu is not quite so obviously seasonal, so that the circulation of viruses can be kind of spread throughout the 12-month period. So that too affects the reliability, if you like, of tests. I think, Steve, you mentioned the issue of variants. Fortunately, with the tests that are done, be they PCR or indeed the antigen tests, the targets are generally the well-conserved parts of the viral genome. So, for example, if you take influenza, the PCR primers are usually targeted at the nuclear protein rather than the hemagglutinin or neuraminidase. And that tends to be much more conserved in different variants of flu that might be present, whether it's H1 influenza or H3. And the same process applies to SARS-CoV-2 as well. And we haven't seen any good evidence with that variants of SARS-CoV-2 or influenza are affecting the reliability of testing at this stage. The other point I wanted to make was we keep talking about rapid tests, but we need to be clear on what we're talking about here. I mean, there are rapid antigen tests, or RATs as they're referred to, at least in Australia, and the sensitivity and specificity of those, particularly the sensitivity, is significantly less than what it is with PCR. Then when you talk about rapid PCR, which the Xpert is a very good example, and we've heard how it's been used in various locations. Those sort of rapid PCRs are highly sensitive and highly specific, irrespective of what variants are circulating. And then you have the sort of multiplex PCRs that Megan referred to, and the time taken to get a result all depends on where your lab is. As Belinda alluded to. So that, for example, in a lab in a major teaching hospital, a lot of microbiology labs go 24/7. So then generating a multiplex PCR can actually be very quick in that environment. But of course, that doesn't apply to everywhere. So I think that, and the other point I wanted to make was what the sort of so, you know, the things that Megan spoke about in terms of what does a result give you and what a negative result does in terms of stopping unnecessary treatments and so on, and what a positive result gives you in terms of being able to start appropriate treatment. And so we certainly have treatments for COVID and flu, and some of you may have seen just in this week's issue of the New England Journal the value of baloxavir, another anti-influenza drug, the value of that drug in preventing transmission to other people. So that sort of stuff is really interesting. And the last point I'll make, Steve, is that there's a public health. There are two benefits also to doing testing over and above the patient care that we've heard about. The first is giving an understanding of what's actually circulating in the community, and therefore what advice public health authorities can give to the community, to closed facilities, aged care facilities, hospitals, etc., etc. So that's really important. And the other thing that testing allows one to do is an assessment of vaccine effectiveness. So, for example, assessing the annual efficacy or effectiveness of influenza vaccine, and same with COVID actually, SARS-CoV-2, then the test results in the community and matching that with the vaccine status gives you an idea of how good our vaccines are. So look, I'll stop there. Yeah.
Thank you so much. So next slide, please. So next issue is so the cost. So what can be the economic impact of having confident molecular test result for SARS-CoV-2 and RSV from a single specimen for hospital bed management? And also, how does it lead to overall cost saving despite the high action cost? So, please answer, Dr. Jordan.
Yeah, thank you so much to APSR for inviting me here. We've looked at this in a number of different ways, and we continue to find the same thing. Having a result, and importantly, as Dr. Dwyer alluded to, having that correct result and having it quickly really makes a difference in terms of allowing clinicians to make better decisions for patients that ultimately result in lower costs. So for instance, as alluded to on the slide here, in a cost consequence model of about 700,000 high-risk patients with symptoms of influenza-like illness in Germany, we found that the faster and improved appropriateness of treatments, and again, some of the other speakers have talked about that you get when you use point-of-care multiplex PCR results in lower tests compared to a number of different alternatives, whether that's antigen testing, whether it's an empiric diagnosis when no diagnostic test is available, or compared to a centralized or batch PCR. That's because the costs associated with the hospital admissions, the ICU stays, the mechanical ventilations, and inappropriate treatments all decrease. There are quite a number of studies that have looked at the relationship between the time to initiation of some of the antivirals we've talked about and the impact in the hospital as well. So it's to say nothing of early administration of Tamiflu resulting in lower length of stay in the hospital, which has been demonstrated by quite a number of different researchers. I'll also say that back in 2024, we looked at the same question in the US and we found really the same results, which I think gives me a lot of confidence in the robustness of that finding and its ability to translate to different contexts and different healthcare systems. Similarly, back in 2023, a hospital that had implemented that point-of-care PCR testing in the emergency department in Germany, they looked at nearly 18,000 patients that received testing for COVID. And they found that because results were available within 2 hours for 75% of patients when point-of-care testing was implemented versus 0% of patients when they used their traditional centralized lab testing, the acquisition costs associated with testing were easily outweighed by the reductions in isolation costs that the hospital had. One of my current favorite studies also gets to that point. I've been talking about this a lot with folks lately, but back in 2020, a group of researchers in Norway asked the question, how much does it really cost us to keep a patient in isolation? And they came up with some really striking and informative findings as we think about this question. They found that the incremental costs of isolation, which were mostly just extra staff time, so the extra couple of minutes to don and doff PPE, the extra little bit of time that everything takes when a patient is in isolation, it costs between 57 to 88 euros per day, depending on whether or not the patient is bedridden or not. Now, that might sound small, maybe 2 to 4 euros per hour. But if you go back to that study I previously mentioned in Germany, you're looking at a difference on average of a turnaround time of about 1.6 hours with that rapid PCR versus about 16 hours with a central lab PCR. So over the course of 13 hours, you're making decisions for those patients. You are perhaps keeping somebody in isolation when they could be cohorted with other patients. And those costs can add up really quickly. That's also to say nothing, as Dr. Dwyer was talking about the potential for transmission if a test gets a result wrong, or if a patient isn't isolated quickly enough. Those costs would be, I think, even more substantial than we could recognize just in the context of a specific healthcare case.
Thank you.
Thank you, Jordan. Yeah, so that kind of segues really nicely into the next question, which is for Megan. And the question is, with those kinds of data outputs in mind, Jordan, where do you think, Megan, that the key points of respiratory testing in your hospital take place, and why do they take place there? Previously, earlier, you had mentioned, key decision-making touch points around wanting to, avert bed management issues if possible. I wonder if you could just tell us, where your hospital places that particular testing and perhaps the reasons for that. I'm assuming that's partly in terms of time, but I wonder if there are other factors at play as well. Perhaps you could elaborate on that for us.
Yes, sure. So currently our rapid respiratory PCR testing is done within our microbiology laboratory, which is on the second floor of our 10-story hospital. Our emergency department is on the ground floor or street level. We did actually previously have the rapid PCR machine in the emergency department, but found it was difficult to maintain a good enough cohort of staff trained to use it. We have very large staffing numbers in the emergency department, doing shifts, changing over all the time. So maintaining a cohort of staff that were trained and maintain the appropriate quality control for the machine within the emergency department was not quite feasible. So it's been moved to the microbiology department, where it's been very easy to maintain quality control and keep an appropriate number of staff tested. It is run 24/7 in that laboratory. And we have a turnaround time of result back to the emergency department of under 2 hours. So that's quite acceptable in our hospital. We have a penalty if patients stay more than 4 hours in the emergency department before being admitted to a ward. So that keeping the test within 2 hours is very feasible. So it's within the microbiology department.
Right, thank you for that. Dr. Fujita.
Okay, next slide, please. So during the Belinda study, so probably there are many problems. So what were some of the implementation challenges for POCT, and how did you overcome them? So for example, Dr. Belinda.
Thank you. I feel like I perhaps need another hour to talk this one through. Working across remote areas came with a lot of implementation challenges. Megan, one of which that you mentioned there about why the device wasn't working in emergency departments is staffing. In remote areas, there is a 50% staff turnover across all these communities. So we would train up staff who would then no longer be there, 1 month later, and then have to train up more staff. We did find overcoming that challenge was training up more Aboriginal health practitioners who were more likely to be from the community that they were working in and more likely to stay for a longer period of time and had that knowledge and in-depth understanding of the community. So we tried to target, I guess, our training with the Aboriginal health staff on the ground. Also during COVID, for those who aren't Australians, I guess the background was that a lot of these remote areas were cut off. They were closed to outside people coming in. So we had to roll out this program without actually setting foot within these remote communities to protect the remote areas. So to respond to this, we established online training. We established online competency assessments. We would FaceTime the health service staff and watch them load a test and make sure that they were competent in running those tests. Since then, we have developed online training modules for people to be able to do at their own pace. And we have offered more face-to-face training for extra support for staff that needed it. One other point for implementation challenges that springs to mind, and I won't take too much longer, is data. People want access to their test results. We installed proprietary software onto the Xpert laptops that came with the devices so that those results could be sent real time into the electronic medical records and to public health departments for notification. So it allowed that public health response to understand what was going on in these remote areas, and to do that across the country in different jurisdictions that had different electronic medical records and different ways of notifying departments was a huge challenge, but we had a very nimble team that rose to that challenge, I guess. Thank you.
Thanks.
And so this is probably going to be the second to last question for our panelists today. I've just thought of another one that I'm going to come back to you with, Jordan. There's something niggling at the back of my mind, so I'm going to talk to Dominic next, and just probably just revisit the issue around variants. I know you commented, Dominic, in relation to the detection of variants and our ongoing capacity, generally speaking, to be able to do that up until now. But I'm just wondering, what you see downstream in terms of any potential ramifications for healthcare systems, particularly not only just here in Australia, but also other parts of the world, in terms of variant curveballs that you might or might not see that are on the horizon, and things that we probably need to be mindful of, either as clinicians and or other health professionals working in not only the respiratory space, but in general. But given our focus today is on respiratory, would you care to comment around that and what you, I suppose, have in your crystal ball, if anything, in relation to those potential variants?
Yeah, sure. So look, clearly variants are important, and everyone was obsessed with variants of SARS-CoV-2 as they've occurred over the last couple of years, but particularly in the first year or so, when things like Delta and Omicron and so on started to appear. And those variants were important because there appeared to be a reasonably good association with different clinical outcomes and different levels of transmission. And possibly unknown at that time, but vaccine escape, if you like. So the initial concern about SARS-CoV-2 variants was justified. I think as time has gone on and the majority of people have been infected, and the majority of people in most countries perhaps, or many countries, have been vaccinated, then that sort of hybrid immunity in the community means that the sort of impact of new variants hasn't been particularly strong, but not to say that that couldn't occur. So that's with SARS-CoV-2. With RSV, we have different sort of subtypes of RSV, if you like, and they sort of appear and disappear in not necessarily predictable fashion, but don't appear to be particularly important in affecting laboratory testing, and probably not a problem with the sort of antiviral agents and monoclonal antibodies and so on being used. And then you've got influenza, where variants, of course, are very important. So you've got variants within H1, influenza H1N1 and H3N2, And those variants are important because you know that as new variants appear, vaccine effectiveness may be reduced. So the monitoring of influenza variants is actually very tried and true, so that there's a WHO national or international program that's been going for 50 or more years, looking at variants of flu and assessing those each year to predict what vaccine we're going to need. Okay, so that's crucial, and that's been ongoing. That doesn't seem to particularly impact on testing, the quality of laboratory testing. So that's important to note. With SARS-CoV-2, because the clinical impact of the variants is perhaps less than what it was initially, people are losing interest in doing the sequencing and so on to monitor for variants. I will point out that the value of the PCR tests, be they the rapid ones like Xpert or the sort of standard laboratory multiplex ones, is that you can use that sample to then do sequencing on that to see what the variant is. So you do have a mechanism for looking for SARS-CoV-2 variants. Of course, obviously, there is a cost in that. And perhaps the last point I'll make about variants is around drug resistance. So the drug resistance with influenza is recognised, but fortunately uncommon. But even in the study I alluded to just the other day with baloxavir and its use in preventing transmission in a household or contacts an index case, even in that study, there was, a 7% or so rate of development of resistance to that agent. So the point I'm trying to make is that you can do testing for drug resistance, and it probably needs to be done in some sort of centralized manner, for example, through the World Health Organization or reference laboratories. But that's a variant that we do need to keep an eye on. It hasn't been an issue of SARS-CoV-2, really, which is a relief, but one needs to continue to do monitoring. And fortunately, with the PCR tests that we have, we can use those samples to do that monitoring. Thanks.
That's great. Thanks, Dominic. And Dr. Fujita, if I could squeeze in one last question. I'm conscious of the time. We're coming up to about almost an hour and a half in terms of this webinar, and I know you might like to bring that to a close fairly shortly. However, we hear, and this is a question for you, Jordan, because we hear more and more, not surprisingly, and with different financial down pressures on healthcare systems and also financial services, the need for more and more evidence around cost effectiveness. And, obviously then often a lot of that gets translated into modelling. Belinda's talked about her program being, starting to look more and more closely at cost effectiveness. We're all accountable to somebody. And so I suppose one of the things that kind of mystifies me a little bit is this issue of what actually does cost effectiveness look like? When somebody says, well, let's do this, let's find out if this is cost effective. Can you give us 3 or 4 key pieces around what that really is, rather than just a cheap test? Because in my world, if you want cheap, then you look for a chicken. But in the academic world and in the clinical world, that's got to translate into some pragmatic realities. And I just wonder if you can speak around that just a little bit in terms of where that translates for you and the work that you do.
Yeah, it's a great question. And the first thing that I would say is I think the terminology and the perspective that we're considering really matters when we talk about cost effectiveness. A lot of times when we use the term cost effectiveness, what we're referring to is really that evaluation at the health system level that's literally looking at what are we spending, how much incrementally does it cost per effect in terms of traditionally quality adjusted life years gained. And that's where we run into our first problem when we're talking about respiratory illnesses, because in general, that quality adjusted life year gained outcome isn't a great fit for an acute infection. It's a much more better fit when we're talking about more chronic diseases. The second problem that we run into when we talk about cost effectiveness is that the health system perspective isn't always the one that matters. We have great stories like we saw in Belinda's presentation, where there's clearly an overall cost savings at the health system level. But when you're talking about your hospital and your administrators and making the case within your context that using a more expensive, faster, more accurate test is going to save money overall. Well, first of all, we're already not talking about cost effectiveness. We're talking about budget impact. And second of all, we're talking about that within the context of the hospital, or maybe even within the context of the lab, because maybe the lab's budget is different from the overall hospital's budget. And that's where I think it's really important for us to be able to look both small and large at what those cost impacts are. I've talked about a couple of the different ones, but I think there are many of these costs that get overlooked because they're not as easy to quantify. And that's where I'd really like the emphasis to be as we kind of look forward to the future, because I think those smaller costs are often the ones that add up and are what offset the potential larger costs in the system. So whether that's the PPE, the extra time that the nurse has to spend with the patient, whether it's the penalties, as one of the panelists have alluded to, on an ER visit that takes too long, whether it's the ER visit just taking too long and that costing more for the system, the length of stay in the hospital. You can kind of ladder up to all of those larger costs. And it's easy to say that, if we can avoid a patient going to ICU, that obviously offsets the cost of doing testing for many patients. But for that individual patient, having the answer faster probably means that we're saving on some of those really small incremental pieces in a way that's saving to the system overall.
Thank you. And my apologies, Dr. Fujita. I just had to squeeze that one in before we probably came to a close. So I'd like to hand the floor back to you.
Okay. But so it's almost time to end. So we learned about the important role of POCT for respiratory infection. So I'm sorry, we have several questions from attendee, but we cannot answer during the webinar. So on behalf of APSR of Cepheid, I would request all the attendees to complete a short survey through the link posted in the chat box. This would help us get you valuable feedback and continuously improve the academic series while also understanding and addressing your diagnosis and clinical needs. So now, I would now like to welcome Dr. Yoshinori Hasegawa, President-elect APSR, to deliver the closing remarks. Dr. Hasegawa?
Okay, can you hear me?
Yeah, sure.
Okay, thank you for everyone. I was so impressed to hear the webinar. First of all, I would like to thank Dr. Fujita and Dr. Stephen Badman for organizing and chair this webinar. And I would also like to thank all the speakers and discussants for excellent speech and fruitful discussion. I believe today's presentations and discussions are an important opportunity to remind our audience of the clinical and economical impact of managing respiratory infections, and to highlight the importance of rapid diagnosis and treatment, and also the importance of public health and its organization. I think we need to continue these kind of discussions for new variants and future pandemic. Now, APSR intends to provide this type of educational information, not only to its members, but to the public at large. I would also like to thank the more than 130 viewers who participated in this webinar. I hope that today's webinar will be useful for your daily practice. Finally, this webinar was supported by Cepheid and APSR. Would like to thank for their contribution. This concludes my remarks. Thank you, everyone.